she trained at
She makes my
BMC.
heart happy.
Did she tell you that?
Yes, yes, she did. Yeah.
All right, ladies and gentlemen, thank you all very much for joining us today. The hour of 10 o'clock has arrived, and that means it is time for us to begin our Health and Hospital Committee meeting. First item of business is to call the meeting to order, so we will turn to our clerk and ask you to call the roll.
Good morning. Supervisor Ellenberg?
Here.
And Supervisor Simitian?
Here.
Thank you. You have a quorum.
Thank you. Presence of a quorum having been established, we will move to public comment. Public comment is that portion of our agenda set aside for comments by members of the public on non-agendized items that are properly within the jurisdiction of our board committee. We have 7 cards today, and so in keeping with our rules, we will ask the clerk to adjust the time to 2 minutes for each speaker, who may take up to 2 minutes. And we'll ask you, if you're able, to just line right up so we can move along expeditiously. We have requests to speak forms from Scott Largent, Lon Nguyen, Mark Quarles, Melanie, forgive me, Melanie M, we're going to say. How's that? And then Craig Maloney and Susan, I believe it's Irizani. Forgive me, I might have misread that. And Carlton Allen. Come on up, folks. Mr. Largent, step right up, please.
Thank you. Good morning, everyone. I didn't really want to steal the thunder of the union back here, so I thought I'd be at the number 7. So a little distracted there for a second. I'm looking forward to today's reentry network meeting. I've been attending these for about 3 or 4 years. I'm starting to figure out the formula here in the county. If you commit a non-violent felony, we're going to help put your life back together. We're going to get you drug treatment. We're going to go ahead and reunite your family. We're going to even do it out at Elmwood. We're going to do it over here at the jail. We're going to enforce all your visitation orders. We're going to help house you. And so I need to figure out, and maybe some of you can help me, what's a list of non-violent felonies I can commit? Okay? I want to be in my child's life. I spent 4 years down here begging. Okay? I've been sober over 4 years. What do I have to do? I have to commit a felony. Anybody have any good ideas for me? Because I don't really want to do a violent felony, but a non-violent felony. That's what I need to figure out. So I'm looking forward to this afternoon at the meeting. This is pretty sad here in our county, and I brought this up for a very, very long time. I sent an email out for a woman that was not brought to her day in court. Now, hopefully some of you actually reviewed it. I know a lot of people don't look at my emails, but maybe you should start watching these videos. That poor homeless woman wasn't even taken to court. They got a stay-away order for her out of Campbell, and no one did a damn thing. No one transported her to civil court. And that's what they're doing to the homeless community, and that's what they're also doing to me right now. They're running me through the civil channel. So hopefully people are going to start paying attention to some of this stuff. So I would appreciate any feedback. Anybody have any good ideas of what I should do? Maybe Jeff Rosen's car out there. Maybe if I steal that thing, let me see, if it's worth over $10,000, is that a felony? Would I be able to see my kid by this weekend? That's the sad part about our county right here. That shouldn't be that way. So thank you.
And our next speaker is Lon Nguyen. Please come forward. Welcome.
Hi, my name is Lan Nguyen, and I work at O'Connor Hospital. Last year, in a room filled with members and our chief elected officer at Local 521, Jeff Smith stated that no one would lose their jobs. Today, we have extra help, provisional, and unclassified workers losing their jobs after decades of service at St. Louis and O'Connor Hospital. Not only is this unfair to these workers, but this is leaving our hospitals in jeopardy with critical short staffing, long wait times, and workers performing duties that are substandard because of the short staffing. This is just one of the many problems with staff recruitment and retention. There are other management problems as well. We have so much hope that the county was going to make these hospitals better. We haven't seen that. Things are getting worse. It's a failed transition, and the county ESA is a big part of the problem. People who are being let go are workers from the community. Patients have relied on them for years. Losing staff that are from our community to replace them with extra help or contracted workers is not only a violation of our contract, but a disservice to our community and what the board has committed to do. You have the authority to ask what is going on and ask Jeff Smith his direction. And Our community deserves a straight answer. Please help us out. Thank you.
And I believe our next speaker is Mark Quarles. Yes.
Good morning. My name is Mark Quarles. I work at St. Louis Hospital. We are seeing our jobs contracted out at our hospital. We are seeing our jobs given extra help, and we are not seeing good county jobs established to help our community. We cannot continue to perpetuate jobs in this county that do not provide benefits and dignity in retirement only to save the county $1. We provide essential services to our community, but yet are ignored. The county has announced 50 positions are being deleted, and we have some serious questions about the impact on patient care. We have demanded to meet, and it is our right under state law. We have requested information, and none has been provided, nor a meeting scheduled. Yet Dr. Smith chose to inform the Board of Supervisors on January 28th that he has the right to move forward with the 50 deletions without meeting the legal requirements to meet with us. The county is proposing to delete 1 HSR at O'Connor and 3 HSRs at VMC. Why, when we provide essential services to our hospitals? The county is proposing to delete 1 office specialist, 2 from O'Connor and 1 at VMC. These are positions critical to our patient care when coming into our offices for assistance. Why delete and not replace them? The county is also proposing to delete a respiratory care practitioner, 2 from O'Connor Hospital. Again, we are asking why. 2.9 hospital service assistants are being deleted from O'Connor and not replaced. 1 hospital assistant is deleted. Why? Again, we are understaffed and overworked. There is a senior biomedical technician that is being deleted from St. Louis Hospital. Again, we're asking why. Thank you.
And next speaker, welcome.
Hi, my name is Melanie Martinez. I work at Valley Health Center, OBGYN, for the last 25 years. Today I speak about the cuts at VMC. Clinical audiologist is being deleted from VMC. We ask why. The county is proposing to reduce the community outreach specialist from 3 to 2.5. That means a reduction of 1 position to half time. 3 community workers are being deleted from VMC alone. Outreach is the lifeblood of our public safety net hospital. We go out to the community, we help educate and enroll. Why are we setting ourselves up to fail on meeting the needs of our community and not help enroll patients in critical services? We have 1 half-time health education specialist is being deleted from VMC. Again, we ask why. 6 health information clerks, 3 are being deleted from VMC. Again, we ask why. 1 IT field support specialist is being deleted from VMC. 3 medical assistants are being deleted from VMC. We are losing critical patient care positions, and the county is okay with providing substandard patient care. A .60 medical unit clerk is being deleted from VMC, all while the county continues to try and delete these positions in order to convert them to LVNs. We cannot slowly lose a critical position in patient care in our hospitals and clinics. We have offered a collaboration to create a career path with the county to move MUCs into LVN positions, like other truly innovative counties have successfully accomplished. But Santa Clara is not open to this. Why not grow our own workforce? The county is deleting 2 mental health workers at VMC. Why? The county is deleting a half obstetrician position at VMC. The county is deleting 1 patient business clerk at VMC. Why? The county is refusing to meet and provide information and to continue to commit unfair labor practices. Thank you.
Thank you. And our next speaker is
Craig Maloney. I'm an occupational therapist at O'Connor Hospital. I've also been an advisor for the SEIU during the negotiations of the contract. The county is deleting 1.75 physical therapy assistant 2 positions. Why? When we are understaffed and overworked and cannot provide adequate services to the patients. The county is deleting 1 senior patient business clerk at Valley Medical Center. Why? Deleting positions that are critical for patient care is not what this committee should be ignoring. We must staff our hospitals if we are to reduce wait times in the ER, reduce visits so that we can focus on patient care at our clinics and improve community health. We are here to let you know that the county is once again refusing to comply with our legal requirements and meet and confer under the Myers-Millis-Brown Act on these add-deletes that impact our workers and are a violation of our contractual agreements. As such, we have filed an unfair labor practice charge against the county, which we are providing to this committee for your reference. We ask that this committee do the right thing and meet with us to protect critical positions in our hospitals, provide a fair process for keeping workers in this failed transition, and work with us to have an effective and efficient health and hospital system. We look to your leadership in staffing these hospitals adequately.
Thank you. Mr. Clerk, if you could take those and make sure that copies are sufficient in number and share them with both the committee and the staff, please. Thank you again. Next speaker, please.
Hi, my name is Susan Arizari, and I have been a full-time physician assistant with Santa Clara Valley Medical Center in the primary care position.
One moment, please.
Yes.
Stop the time, please. And if you could restore the time, please, David, but if you could also give us a little more volume so we can hear Mrs. Ari. Thank you. Sorry for the interruption.
That's okay. So my name is Susan Arizari. I'm a physician assistant for the general surgery department. I've been a full-time employee for about 4 years. September 4th, I was walked off the job for a requirement that is not, for a reported requirement that's not a written requirement for the medical staff rules, for the medical staff bylaws, the job requirements, or as needed for renewal for privileges. Sorry, I'm a little bit nervous. It's been a little bit stressful. I'm 5 months pregnant. Sorry. Yeah, can you take over?
All right. Okay. I think she's done. I got you. I got you, sister. I got you. I'm going to continue. My name is Carlton Allen. I'm an LVN. I've been a steward in this county for the past 5 years. I've been working for this county for 20 years. I've been on her case since pretty much the inception. A PA taken off of work because of a change that her manager decided to change without coming to you, approving it. We go to ESA, we go to Labor Relations backs it up, says County Council approves it. That's just one of the issues I'm here to talk about. I want to bring up a gentleman that was just released. He's not here. He's at home drinking. 33-year worker at O'Connor Hospital, Vietnam vet. He was let go. I got a call that he was going to be let go by letter in the mail. This county is responsible to take care of our vets. He is at home drinking. His wife is dying. What we got from, I sat in front of management in ESA at O'Connor, a cold. No information about where his medical benefits are going to come from. No last check. The answer that he got on his last thing was, we'll send you a check in 2 weeks. The coldness of this situation, I have been working on this transition from back in 2018. And if I tell you stop talking to management and stop listening to the ESA, you guys need to start talking to the workers. If you do not, this transition is going to keep failing. I beg you guys to talk to us. I am going to be here at every section to make sure you guys get as much information out of me as possible, because something has to change. Something. They won't treat me like this because I'm a permanent employee, and I'm going to speak up for myself. But a 33-year-old vet is at home today drinking because of this county.
Thank you all for being here. Let me just check with the clerk to make sure we have no other cards under public comment. We do not. Thank you again. That completes item number 2, which is public comment, takes us to item number 3, which is to approve the consent calendar and changes to the committee agenda, if any. Supervisor Ellenberg, could I get a motion to approve the consent calendar as contained in our published agenda, please?
So moved.
Thank you. And without objection, the consent calendar will be approved. Supervisor Ellenberg, my understanding is you have a hard stop at noon today, so if we have reports under item 9 that remain uncompleted at the time you have to depart, I will probably simply ask for a motion prior to that time so that we can get that squared away. Okay? That takes us to, or would take us, item number 4, which is to receive the report from the Public Health Department relating to the novel coronavirus, but that is a time certain, not to be heard until 11 o'clock, so we will make our way through the rest of the agenda, folks, and then come back at 11 o'clock sharp to pick that item up. That means then that we're going to go on to item number 5, which is to approve appointments and reappointments and privileging actions. And let me ask staff to present on that. We do have 2 cards, and I will call them up after we've got the report and request.
Good morning, Board of Supervisors. My name is Yvonne Karanis. I'm the president of the Enterprise Medical Staff, and I'm here to present the credentials report and answer any questions.
Thank you. Supervisor Ellenberg, no comments or questions. We do have cards from Susan Irizami and from Carlton Allen again on this item. Folks?
Okay. So I was walked off September 4th for a certificate that is not currently a written requirement. The director of advanced practice sent an email admitting that she had submitted the changes to the job specifications and requirements to ESA, but those are still sitting in queue, therefore enforcing a unilateral change in working conditions that has not been negotiated with the SIU, discussed at a meet and confer, or approved by the Board of Supervisors. Working with labor relations has been very difficult and very stressful. And specifically with Matthew Cottrell and Teresa Moran has been very, very difficult. Teresa Moran has personally told us that the medical staff can change the working conditions without having approval from the Board of Supervisors, which I have proof of in an email, that they can enforce these changes without a meet and confer, without having approval of the Board of Supervisors, which is wrong. This stress has been exponential, and I lost my child care. We lost our health insurance. That's going to cost me $12,000. And the process is not fair how it's happening. I am in the process of trying to regain my certification because I know that eventually it will be a requirement after the appropriate steps are being taken. But there are many job opportunities I can do at work with it.
I got you. All right, so it's Carlton Allen again. So let me just summarize. She's let off of work. They make a certification. The classification never was changed since 1977. We go to a meeting, same day the meeting happens, where there's a statement by the director of her department that says she's never been credentialed. Same afternoon she comes to you guys and Mr. Simidian, they had her, you guys approved it. Same day, oh, she's never credentialed. They come here and they have her name removed from her privileges. I have tried management. We said, hey, look, we agree that this is probably necessary, but let's see if we can get this woman back to work. There's tons of things we can do. We've been told everything from she can't bill. We have been told that the committee is a secret committee, that we're not entitled to information. We have been basically stonewalled. We've asked for very simple things in this case, and the simple thing comes down to it is they're costing patient care because there's claims that their intention was to have this certification. There's no movement. I have said this, and I said this to Mr. Smith. ESA is a problem. You guys have had an evaluation of ESA. Everything that was in that evaluation, ESA has said that is their practice. The committee and the company that evaluated them basically ripped them to shreds and said that they are not following basic practices. But we are still allowing them to run this department. Since Lisa and Sandra Poole has left, I have witnessed a degradation of that department to a point where it's unrecognizable, but somebody has to look into this, and somebody needs to get this woman back to work. Thank you.
Thank you. Let me confirm with the clerk, we have no other cards on this item. Dr. Smith, I know we typically cannot accommodate action on individual personnel cases on something like this, and obviously on public comment, we're precluded from taking action. But I wonder if there's anything you can and would like to share with the committee briefly about how to make sure that the case gets the appropriate follow-up.
Yes, the case has been followed up in many ways. It's primarily a medical staff issue that the individual doesn't qualify to do the job. So from a medical staff perspective, there's no privileges that can be rendered. And if you don't have privileges, you can't do the job.
I wonder if we could ask for an off-agenda confidential report on a personnel basis.
Sure.
Thank you. Would appreciate that. Thank you again. And folks who are here, if you could please hold off on commenting from the audience. I'd appreciate that. That takes us to formal action on this item. Supervisor Ellenberg.
Move approval.
We have a motion to approve. Anything else at this time? No?
No.
Then without objection and hearing none, unanimously approved. Thank you very much.
Thank you.
Thank you. That takes us to item number 6, which is to receive the report from Santa Clara Valley Medical Center and the Office of the County Executive relating to the Behavioral Health Services Facility on the Santa Clara Valley Medical Center campus, scheduled to open fall of 2023. Dr. Smith, who would you like to have begin on this?
Jeff Draper will start. We have to step out for a moment.
Great, thank you very much.
Good morning, committee. Jeff Draper from the Facilities and Fleet Department. With me, I'd like to introduce the people who are going to be part of your management team for this particular project. To my right, to your left as you're looking, is Curtis Ohashi, our Chief Operations Officer. Our project manager will be Doug Koenig, who is our Deputy Chief of Facilities and Fleet. And our project, his assistant, I should say, is Kamal Sodi, who is going to do a lot of the up and down lifting on this project.
Great, and excuse the interruption, but just to make sure I know who's who, Mr. Koenig, could you raise your hand again so I can see who you are? Thank you. Now I got you right there in front of me. And Mr. Ohashi, nice to see you, and Mr. Sodi. And am I pronouncing all of your names correctly, gentlemen? Thank you. All right, please proceed.
To be being responsive to last month's HHC, we provided a timeline that meets your expectations, I believe, and it's something that we were excited about. We think it's achievable, and working preliminarily with our architect, especially on the design phase of the project. And so we're going to be tracking to this schedule throughout, with a delivery of construction at the end of October 23 and it looks like startup and open to patients in November.
Thank you for that.
From a project delivery point of view, we're planning on looking at the construction manager at risk as our project delivery method. We think that particular delivery method may allow us to fast track the project so that we can meet the expected schedule. And with that, I'll stop and let, excuse me, Curtis, do you have anything you want to add today? Okay, all right. With that, I'll stop and let you ask any questions you may have.
Thank you. Let me see if we have any cards on this item. We do not. Thank you. Supervisor Ellenberg, I've got a couple of comments and questions, but defer to you for the moment if you like.
Yes, I'm happy to be very brief. I really appreciate the sense of urgency that Supervisor Simitian has brought to this project, and I want to make a particular thank you to staff for the update and for including a stakeholder meeting for the neighborhoods that are surrounding VMC. It's a concern that I am hearing from my constituents, and I want to be proactive with you in making sure that we've got great community buy-in. Thanks.
Thank you, Supervisor. Gentlemen, I'm hoping that Dr. Smith and Ms. Marquez will be able to join us again before we complete the item. But I'm going to do something today that I'm going to do at every meeting henceforth, which is, first I'm going to say thank you. I am looking at the timeline on page 2 of 3 in the packet, and I'm looking at, this is packet page 14 for those who are using the packet, and I'm looking at 3, to me, key dates, and these are in your report to us. And thank you. These are the dates that I asked for when we met last. The design completion date, the construction commencement date, and the open to patients date. And as I think you know, if you either were here, watched, or heard about the last meeting, I had concern about the fact that, at least based on the paper we had in front of us, we had 2 years slippage in the projected completion date. We had that conversation. The administration was good enough to say we can get back on track. But I'm going to ask at every meeting, are we still on track for each of these 3 items? And I'm going to ask you, Mr. Draper, and I'm going to ask you, Mr. Koenig, because it seems to me you're the 2 guys I should be asking this question of. So, Mr. Draper and Mr. Koenig. It says here that the design completion is scheduled for February 2021. Are we still on track to meet that date? Gentlemen?
Yes, we are.
Mr. Draper? Okay.
Yes, we are.
And that we could then begin construction on February 2022. Are we still on track to meet that date?
Correct.
Yes.
Thank you. And then open to patients, November 2023. Are we still on track to meet that date?
Yes, we are.
Okay. Now, gentlemen, I'm going to ask you this question every single meeting for the rest of time until we open the building. And so if we get to 2021, and after months of being told the answer was yes, there is no design completion, I think you can understand that there'll have to be some consequences. We can't keep doing this. I've made my case clear. Thank you. Now, that's a pretty ambitious construction schedule. Am I right about that?
Yes, yes it is.
What makes you think we can meet that very ambitious construction schedule? That's not a rhetorical question. That's a serious question.
Well,
Please.
we met with the architects, the architect team, HGA, following the last meeting. We told them that we needed to move up their design schedule. They went back, they looked at it, they came back in and we met, and they felt confident that they could meet that design schedule. They said that it would probably require some sort of sequential packaging, such as preparing plans and specs for a foundation ahead of the completion of the design, giving you the ability to start the construction of the foundation while other activities are going on. So based on their input, they were very positive that they could meet it. The thing we'd be concerned about is it's such a tight schedule that if anybody desires to change the scope, add scope, delete scope, that would really put it would cause delays.
Duly noted. Thoughts about the OSHPD process, which was highlighted in the report as a place that is to some extent beyond our control?
Regarding OSHPD, this schedule actually allows about 12 months for review at OSHPD. Assuming, that's with one package. When they bifurcate this process and go with separate packages, we haven't seen the complete schedule on how that would work, but 12 months would certainly be possible. It's also aggressive, but when they break it up, it may work to our advantage.
And your thoughts, if any, today, and if you'd like to wait until the next meeting, that's fine, about how and when we should be approaching OSHPD?
That, we've not gotten that complete schedule yet. Do you have that? Or, no,
Yeah, I want to make sure we avoid a situation in which OSHPD said, gee, nobody came to us in a timely fashion. So when do we need to be knocking on the door or picking up the phone or sending the first flurry of emails to OSHPD saying, hey, here we come, please be ready for us, and please understand the sense of urgency that we bring to the project?
I would say that we need to do that before we get to the next HHC.
So between
now
and next month. If we could ask you to sort of come back on that, and keep in mind that you have members of the board who are prepared to extend themselves to be in touch with folks at the state level and work with folks there to see if we can't make sure that the project is handled on a timely basis. Thoughts about whether or not some kind of bonus for timely completion is lawful and appropriate, might be helpful?
I think it's something worth looking into, Supervisor, and we'll do that and report back to you on the next meeting.
Thank you. Mr. Draper, your colleagues there at the table may not recall, but I know you will recall at various projects, I've expressed concern about whether or not our liquidated damage clauses are sufficient to compel timely performance. I'd ask you to look at that. That's essentially the flip side of a bonus for timely completion. I understand that we're in a busy market, gentlemen. I get that. I know that there are challenges with that. But, our job is to figure out how to meet and master those challenges. I had mentioned previously, Supervisor Ellenberg, the desire I have to find some way to provide some oversight independent of county staff that can provide assurances to our board that things are in fact on track so that we don't have any surprises about failure to move on a timely basis. I'm going to ask Mr. Draper, you and your team to be in touch with the Harvey Rose organization, our management audit folks, to discuss what such an oversight component might look like, and to work with Mr. Press and others in the county counsel's office about how that might be structured. I understand that's not something we can do unilaterally here at the committee, so I'll want to ask Mr. Press as well what it would take in terms of formal action by the board, if any, to make sure that we had either independent of or contracted through our Harvey Rose organization someone who can provide that kind of oversight. Basically just an independent outside body that has professional expertise that I don't believe our board members are likely to have. I can't speak for others. I can certainly speak for myself. And to provide us with regular assurances that we are in fact on the schedule that we have set forth. And then prior to the next meeting, or I guess I should say leading up to the next meeting and at the next meeting, I'd like to ask Dr. Smith if he and his team could talk to us a little bit about the possibility of commencing services in existing facilities prior to the opening of a new facility. One of the things, and I know Mr. Lorenz is not here today, he's out sick, which we wish him well. But I know we have, at least in terms of licensed beds at the multiple facilities we now are responsible for, we have a surplus of licensed beds. So I'm wondering whether or not some of those licensed beds might not be potentially dedicated to the purposes of adolescent psychiatric care as an interim, both to address the urgent need and also so that we have some sense of tangible commitment to delivering these services, which we've not yet been able to do. Dr. Smith, I see your light is on, sir.
Right. I think we theoretically, I mean, I have to check with Paul to be sure, but I think we theoretically could utilize some beds in O'Connor since they're not full. We'd have to apply for modification in some of our licensing and make sure that the facilities were adequate. You know, there are a lot of physical plant requirements having to do with creating psychiatric beds, but certainly we can look at that and get back to you.
Thank you. I would appreciate that. And, you know, even if we took as long as 2 years to stand up something like that, that would give us a 2-year head start on delivering these services. It would also mean that once we had a dedicated facility, we had once we had a dedicated facility, we had service experience that would allow us to move into that facility with some clear understanding of what it takes to deliver these services. It would also mean that in the intervening years, hundreds, if not thousands, of these kids would be served here in our county rather than being shipped to other parts of the Bay Area and beyond. All right, we'll ask for that then at the next time. Dr. Smith, I know you had to step away to deal with the challenge of the moment. Anything else you want to add to the report? And I do have one set of 3 questions that I've asked your team here that I'll ask you in a minute, but let me see if there's anything else you wanted to add.
Only that I'm very confident we can reverse engineer the time schedule and meet the deadlines. We've got the architect on board. At this point, I think the rate limiting step will be OSHPD, and we'll be pushing hard on OSHPD. I think we've got a schedule that we can meet.
Thank you. So I'm looking at packet page 14, page 2 of 3 in the staff report. This is where the timeline is with the 3 key dates that I had asked. We highlight design completion by February 2021 and construction beginning February 2022, and open to patients November 2023. Is it are these dates still achievable?
Yes, I'm confident they're achievable.
Thank you.
You know,
all right.
The design completion we will really typically is 2 components. One is sort of a conceptual design, and the other is the architectural design. We're compressing that, and the construction we will be building in incentives for rapid construction, and the program issues that we need to address for patients we will be working on concurrently. So I'm confident we'll make it.
Thank you very much. Gentlemen, thank you. Look forward to working with you in the months and years ahead. That takes us to, well, forgive me, does require a motion, Supervisor Ellenberg, to simply receive the report at this time.
So moved.
Motion from Ellenberg, no cards on the item. Without objection, hearing none, report is deemed received. Thank you. That takes us then to item number 7, which is to receive the report from the County of Santa Clara Health System relating to healthcare coverage expansion here in Santa Clara County. And let me just say before I turn, I believe, to Mr. Santiago, that we have some paper that has arrived just recently about potential expansion, but as the enclosure indicates, to some extent this builds on an earlier report that we received at this committee. So I'll turn to you, and I mentioned that just so folks aren't confused if we are jumping back and forth between the two documents and the two conversations. Mr. Santiago?
Yes, and Mr. Chair, good morning, Chair Simitian and Supervisor Ellenberg. And I'm conscious of the clock as well, so since we do have an agenda item 11, you let me know in terms of whether you want me to cut it short or go as compressed as
We're
possible.
okay if we have to literally just, am I dating myself if I say TiVo you and just stop you in real time and then come back to you after the 11 o'clock report? We'll do that. But I know we've continued this item and it's a priority. So let's make sure we give it the time it deserves and requires today.
Well, given the alternatives, TiVo, I'll take TiVo as opposed to some of the potential alternatives here. We have for you, as you indicated, a very comprehensive report that gives you a status in terms of coverage, both insurance as well as health coverage and access programs that we have here in this county. Under your leadership, as well as the full board, we have been a leading county in the implementation, not only of the Affordable Care Act, but then also our own local initiatives and expanding access to care. So that report gives you a very comprehensive view in terms of where we stand. It compiles prior information as well as gives you some best available information that we were able to gather from recent surveys. As you know, the three main ways that ACA, which is the National Health Reform, expanded coverage was through Medi-Cal expansion, the insurance marketplace reform, which we call Cover California here in the state, as well as the individual mandate. The significance of these three is that 90% of the federal funding went to these three major initiatives. So when we think of ACA in terms of or commonly known as Obamacare, these are the three major tenets of that national health reform. And fundamentally, Medi-Cal in particularly, not only does it mean a lot for our low-income residents in our community, but it really transformed that program. Medi-Cal expansion. Traditionally, if you recall, from your earlier days at the state, Medi-Cal was perceived as a welfare program, primarily for women, children, low-income, poor adults, and disabled populations. Medi-Cal is not perceived as, quite honestly, a safety net for all Americans in terms of public insurance. That's been, if we could go back to that other slide. That's been a huge transformation as part of ACA, even though there's more recent attempts to not only repeal and replace ACA, but then also to roll back some of the benefits under Medi-Cal. The general public perceives Medi-Cal as fundamentally something that is very popular. And as you know, healthcare is still a big topic nationally in terms of the national elections coming up. For us here in Santa Clara County, we've made tremendous progress. Almost 96% of our population are covered through these various programs that are available, and we'll give you a little bit of stats related to how that breaks down. And then, of course, we continue to follow very closely what the state of California is doing related to expansion of coverage. Most recently, they have commissioned Healthy California for All to look at not only single payer, but potentially other alternatives. And so therefore, we make sure that not only our policy initiatives, but also our influence is carried over in terms of the state implementation. That commission has two reports pending to the legislature, one in July of this year, 2020, and a second report in February in terms of how to finance those particular initiatives here in the state of California. Next slide. Now, there's a lot of options available for residents, and this gives you a full list of things. Some of it is the reason why it's so complicated and sometimes fragmented in terms of the health care is because a lot of people have a variety of different programs that could qualify. Commonly, the low-income qualify for a variety of different programs. So the child might be on Medi-Cal, the parent might be another, employer-sponsored. There's a variety of combinations here in terms of individuals, families, and communities. So you get a snapshot view here of all the variety of different things that are available to Santa Clara County residents. Employer-sponsored insurance, as you see, it's one bullet there. That's the majority still of our residents qualify under that. 58% based on the Community Health Information Survey. That's a sample that's drawn from the population here. Report that 58% of them report they have employer-sponsored insurance. Medi-Cal, whether it be Medi-Cal state-only Medi-Cal or share of cost or just regular Medi-Cal, as well as Medicare, which is normally what we consider to be the public insurance, makes up for about 30% of the population. So that's how it breaks down. And then going down the line, the Primary Care Access Program, we've had discussions here. That's the one that provides funding to community clinics to allow those that are 200% of federal poverty level and below have access not only to primary care but also comprehensive care at VMC. And then there's a variety of other programs available. Next slide. Despite all these options, we still have people that remain uninsured. And as you can see here, it's a snapshot view of statewide. If you look at not only uninsured for those that are eligible for a variety of different programs, but also the undocumented. Now, normally people think of the undocumented as the only remaining uninsured, but as you can see from this graph, there's actually more people that are eligible for a variety of different programs that are actually uninsured. So we wanted to just make sure that that was noted here. It's particularly for that population below 65, because once you're 65 in America, you essentially have social insurance, which is called Medicare. So here you see a snapshot view in terms of statewide. We know here locally we have about 67,000 residents that are still uninsured, even though smaller amount than statewide, obviously in terms of percentages, we still have a ways to go in terms of having universal coverage. Most of the population that's uninsured is the low and moderate income population between the ages of 26 and 65, and then, of course, the undocumented. Next slide. One big issue, which, as you have identified, Mr. Chair, is the affordability. So even though there's a lot of options available for individuals and families, and obviously there's been tremendous progress made under ACA, the issue of increasing cost continues to be predominantly the big policy issue, not only at the state, but then also at national government. And this one gives you a snapshot view, this graph. These are people that are actually getting employer-based insurance and seeing how much they're having to pay out of pocket. Now, affordability is seen at multiple levels. Obviously, from a payer perspective is the total cost of care, how much we're spending as a society or a variety of different programs for individuals in terms of health insurance and coverage, as well as co-payments when they go and visit the doctor, as well as share of cost in a variety of other forms. This gives you just the employer-based coverage, but it's a real good sensitive indicator in terms of what people really feel, what they think in terms of regular citizen on the street, that they're increasingly having to pay out of pocket, whether it be sharing the premium in terms of premium contributions or whether out-of-pocket spending when they go visit the doctor or the hospital or the emergency room.
Mr. Santiago, excuse the interruption before you move on. I have joked from time to time that many of the charts and graphs we get leave me more confused rather than more clear. But I have to say, notwithstanding all the colors and moving parts here, I actually find this a very helpful chart in terms of understanding both the growth sort of at the total level, but also the impact on individual family premium contributions, out-of-pocket spending. I think it conveys a lot in a single sheet. So thank you. I just, as someone who from time to time has expressed frustration with the difficulty of getting the information in a clear way, I think this one's a helpful one. Thank you.
And this is probably where you hear the most when you hear about constituents, because this is what they feel in terms of the pocketbook, so we want to make sure you have that available as well. Now, at this point in time, next slide, we're not recommending a particular coverage program. I indicated, you mentioned before the holidays actually, come back in January in terms of concrete actions that we can do. We reported 3 concrete actions as part of my director's report in January. What we're pursuing on this particular one, which will require a policy position by you and your fellow members of the board, is that we still make strides in terms of universal access, because this is what the ones that our residents are really feeling, and it's responding to, obviously, their pressing needs. With the purchase of the 2 hospitals, O'Connor and St. Louis, we recognized there was a need to standardize and streamline a lot of the payment options available to residents now that they're part of the county health system, as well as the enterprise. And one of the things that we're recommending here, and we're pursuing based on your guidance, is to essentially guarantee discounted medically necessary care for persons below 400% of the federal poverty level. The reason why we landed at 400% of the federal poverty level is 2. One of them, that's Cover California, obviously, in terms of the federal subsidy. The state subsidizes up to 600% based on the recent governor proposals and adopted plans at the state of California. 400% also benchmarks very closely to what our county has considered a livable wage. In terms of, I think livable wage is $23. 400% is about $24 an hour. So we believe what we're recommending here is that with your guidance is to pursue this, to make sure that whether patients show up at our ambulatory care facilities or one of our hospitals, that we actually provide essentially full financial assistance for the medically necessary care for those persons that fall below that poverty level. There's still some work that needs to be done, working closely not only with our programs but also with County Council to make sure we meet the legal and regulatory requirements associated with this policy. And so we'll have a specific proposal for your consideration once we've fully vetted all those issues. But at minimum, what we're proposing, we should not be sending patients to collection agencies if they fall under this category.
Can I just interrupt for a second?
Sure. Before I go to Dr. Smith, however, and Supervisor Ellenberg, I want to try and place some of this in context very briefly. Going back to the January 22nd memo, I had asked for essentially 3 actions that might provide for broader coverage. And there was no magic to the number 3. It just seemed like we could keep track of 3 things, and I was asking, as your memo indicates, for the 3 items that were most actionable. And at the time, the 3 items were described as efforts in support of Medi-Cal expansion, and accessing state funding pursuant to AB 74 through a larger effort. But the one thing that would fall squarely on our county would be an effort at what was described in that memo as reducing barriers. Right. I believe what we have in front of us today is that reducing barriers plan, or at least the basic components of a plan.
Correct.
And as your memo for this meeting indicates, that entails a lot of moving parts, but is generally designed to ensure that folks of modest means have, as the slide says, guaranteed and discounted medically necessary care depending on their level of income. Yes?
Correct.
Thank you. Dr. Smith and then Ms. Ellenberg.
I just wanted to highlight one part of the presentation that is troublesome, that we still haven't got a great answer to, and that is the issue of the population that's eligible for programs but not enrolled for numerous reasons. And, you know, we found that there are many, many reasons why people are not enrolled. You know, some might think that it's a program that will report them to the feds. Some might think that it will cost them more. Others just aren't aware of the programs available. Some feel that they don't need this service right now. They'll wait until they actually need medical care. But it's a significant percentage of the population of the uninsured, and I don't think we have a great solution to that part of the problem. We certainly can enroll people who present themselves to be enrolled, and we certainly can create a new level of care where we cover everybody up to 400%, and anybody who needs care, but we still will have that problem with getting people to enroll who don't want to for a number of reasons.
Thank you. Supervisor Ellenberg.
Thank you. I want to go back to that same slide too, Dr. Smith, that you were just on. I think it's the third slide. They're not numbered. Nope. Yep. I'm looking at of the 3.5 million Californians, 610,000 are eligible for Covered California who live under 400% of the federal poverty level. This is the population that we are talking about. And do we have a sense of, number one, estimate of the number of people and estimated costs for Santa Clara County, or is that something that would come in the next iteration here?
We do give you in the documents a variety of different scenarios, because a lot of it depends on their income, the household size, the size of the families, those kinds of things.
But we are talking about supplemental or gap covering. Is that correct? Not fully insuring.
Correct. We're not proposing a coverage program. We're not proposing an insurance product. We're proposing just to eliminating the barriers and allowing people to get access to care at our facilities.
And when people approach, if they are not yet covered, we will first get them into Covered California or Medi-Cal or whatever they are eligible for.
Many of our programs are designed to give that's part of our financial assistance, to be able to walk through the different patients that have particularly big charges, to walk them through the options that are available, as well as kind of encouraging and support them to fill the paperwork, whatever needs necessary. I think some of them have co-payments. Our surveys, local surveys indicate that at least for 30% of them, the cost is associated with enrollment. It's a big barrier for them. So at least the way we're thinking right now is that we may be forced to send the bill about co-payments. We may need to be, because of law and regulation, send them a statement of charges, for example. But we would not send them to a collection agency as a result of it. We still help them to try to get them enrolled.
And we can make that clear to patients that even though we're sending you a bill, if you don't pay it, that's okay?
Yes, we can communicate that through both written as well as verbally.
Okay. My other question is about the timing. The report mentions the many federal and state changes that are happening. We know with conversations that are teed up for this committee that there's still a lot of uncertainty about the Medi-Cal coverage, about Healthy California for All. What are the pros and cons of starting something like this now as opposed to waiting, several months to hopefully not more than half a year or so to see what falls out at the federal and state levels before we implement a new program?
Well, the big pro in terms of this approach is that we would not be creating barriers to access to care, because one of the problems that many people face is that because they don't have insurance or coverage, they delay prevention services, they delay treatment. So we're trying to eliminate as many of those barriers as possible, tell them that we're here to serve you. We're also here to help you process whatever applications you need to process, whether it be for Medi-Cal or Covered California or other options. So I think that's the big pro, to help us, at least at all our facilities, put that forward.
And a con of doing it before we have certainty about the federal and state?
Well, there's different views on that. One of them is that if we make it too easy for people, that they're not going to follow through. That's generally very simplified, but that's normally kind of how it gets expressed, that you need to make it a little bit painful in terms of charging or cost in order for them to pursue those things. I think my experience, that's the very minority. Most people recognize that, as indicated, Medi-Cal and Covered California are actually valuable The surveys indicate that people are actually signing on to these things. They're actually following through. I think cost is a big consideration, so we'll try to remove as much of it as possible.
All right.
If
Thank
I
you very
could
much for
lean
that.
in on this before we go to our 11 o'clock time certain item.
Yes.
So we'll ask you to hold that thought or those many thoughts. Mr. Santiago will come back to slide 6 when we complete the next item. Before that, however, Supervisor Ellenberg, I will just say, I think if we, I see Mr. Margolin here, or at least I was seeing him through the cameraman there. This is a question we might ask him when he gives his report, and I know if you have to step away at noon, you may not be here for his report, but we can ask your staff to convey his reaction on this issue, or we could even pull him up early. But my experience has been if we wait until there's certainty at the state or federal level, we could be waiting a very long time. And so I think your point is a good one, which is we obviously have to be mindful of directions at the state excuse me if I said state and local, I meant state and national, forgive me, state and national level. But I think the 7 years I've been on this committee, so we've not had a moment of certainty. And in fact, I remember following the presidential election in 2016 and the congressional elections at the same time, when we came back for our first Health and Hospital Committee meeting, Supervisor Yeager, who then chaired this committee, I think was anxious about our ability to move forward. And my reaction at the time, and I think I said it in just these words, is damn the torpedoes, full speed ahead, that we couldn't sort of let fear of the future compel us. So I think, well advised to be sort of thoughtful and smart about what the direction at the state and national level are, but certainty is not going to be coming our way anytime soon.
Fair comments. And Bert, if I miss hearing you live today, I will certainly listen to the video of your comments later this afternoon. Thank you.
Thank you. Then, without objection, we will hold the current item that we're on, which is item number 7, and we will return to the time certain item number 4, which is to receive a report from the Health Department relating to the novel coronavirus, which has recently been renamed, and we'll turn to Dr. Cody for that. Dr. Cody, thank you for pulling together the explanation of the work you've been doing in this area. I'm just going to sort of share with folks here at the dais and in the chambers my request was that we get today a clear understanding of the nature and extent of the problem, a clear understanding of what our county is doing by way of response, and a clear understanding of what, if anything, the public should be doing by way of response. So I know you've got a presentation, and look forward to having it. And then as Supervisor Ellenberg and I sort of go back through that and follow up with you, those are sort of going to be the 3 questions that I'll continue to sort of focus on, which is the nature and extent of the problem, what is our county doing to address that problem, and what should members of the public be doing to address the problem as well. Thank you. Why don't we turn to you, and I see the presentation is up on our screens.
Wonderful. Thank you, Supervisor Simitian. I'm Dr. Sarah Cody, the Health Officer and Public Health Department Director. And thank you for advancing the slides. I really appreciate it. So this is, if you could go back actually to the first title slide, the one point that I really wanted to make is I'm going to be presenting about a rapidly changing situation, and the name of what I'm going to discuss has also been rapidly changing. It's difficult to keep up with, and my apologies in advance if I use an old name. I just might do it. So the virus is now officially called Severe Acute Respiratory Syndrome Coronavirus 2, or SARS-CoV-2. It's what we've been calling the novel coronavirus or the new coronavirus. And the disease that it causes is called COVID-19. That's not the name of the virus, that's the name of the disease. So that's technically what's correct, and I may misuse the names because I'm still not used to the new ones. So by the end of this presentation, everyone in the audience should know enough to come serve in our Medical Health Joint Operations Center, and we will be calling on you and deploying you to come work for us. Next slide. You can So coronaviruses, these are really interesting viruses, and they infect a wide range of host animals, including mammals and birds. Just 7 of the coronaviruses are known to infect humans. And generally the way it goes is this particular new virus is related to a virus found in bats, like the SARS virus. And then it jumped, like in SARS, it jumped from a bat to a civet cat to humans. We still don't know what the intermediate animal is in this case, but the virus is related to bats. So some coronaviruses cause really severe illness, like SARS that we had in 2002, 2003, and MERS, which is ongoing. And then some just circulate regularly and cause the common cold. So big variety of viruses within this family. Next slide. So I put this slide up. This is now quite outdated. This is just from last Friday, Valentine's Day. But this is a snapshot from the WHO webpage, and I think it gives you a sense of a couple things. One is you see on the lower left, these are the cumulative lab-confirmed cases, and you can just see the incredibly steep increase. This all happened very fast. I also just want to note that there's now over 24 countries around the world that have been affected by this new virus. And this virus actually spread from a single city, Wuhan, in the Hubei province in China, to the entire country of China in about 30 days. So we've never really seen anything quite like this. It's the rapid spread that's really caught our attention and mobilized the public health community and many others around the world. So the working theory about this virus is that it emerged in a wholesale market in Wuhan, and then due to high mutation and recombination of the virus, adapted to become increasingly efficient at human-to-human transmission. So now we know there's human-to-human transmission. And the numbers on this change really fast, but the new numbers I have for today is that globally there are around 75,000 cases and about 2,000 associated deaths. So now I just want to show, next slide, this is a little busy, but the timeline of events, and just show you what we were doing in Santa Clara County and what was happening in the world and the country at that time. So the virus wasn't even first discovered in Wuhan until December, and we first became aware in the county in late December when reports started showing up in ProMed Mail that we follow. So that's how we first became aware. Then fast forward just, really a little more than 2 weeks later, January 17th, an airport screening began in the United States, San Francisco, JFK, and LAX to screen passengers returning from China. That's really when the activity locally started to pick up. And then, of course, January 21st was the first case in the United States diagnosed in a resident of Washington State. Our activity, shortly after that, we formally activated our Public Health Operations Center. We do that anytime the demands on a program exceed the staff in the program. And so we activate so that we can have a formalized way to bring in resources and support a single program. So we initially activated January 24th, really just out of a conference room in the Public Health Department. And then things started to move very, very quickly. Our first case, as you may recall, was diagnosed on Friday, January 31st in the morning. The second case just 48 hours later on February 2nd. And all of this was the intense activity was happening in our department as nationally or internationally, the WHO declared a public health emergency. The U.S. declared a public health emergency. and there's just lots and lots and lots of activity. And I can come back and provide any extra details that you're interested in on the timeline. Next slide. So before I go any farther, I just wanted to step back and reiterate some real basics. This is bread and butter work that we do in public health every day. We're not usually on the news, and I'm not usually reporting all these details to Health and Hospital Committee. But this is the pattern of work that we're doing is the same work that we do for measles, for meningococcal disease, for tuberculosis, for syphilis, for many other communicable diseases. It's just now expanded and in response to a virus that we still don't know that much about. So there's three main components. One is you have to have good disease surveillance. So you have a case definition, you define what you're looking for. It might be what symptoms somebody has. It might be the result of a lab test. It might be based on what the exposure was. In this case, the exposure is a travel history that we're really interested in. So you need good disease surveillance so you can count up what's happening. Second is good case identification. So once you pick up a case on disease surveillance, all of the work that goes into deciding whether you need to isolate that person. In this case, we isolate cases that we find, and good contact tracing, which is really what I call the basic shoe leather epidemiology. You talk to the case, you find out everywhere they were during their incubation period and while they were infectious, who they were in contact with, et cetera, et cetera. It's quite a bit of detailed work. So those are really the three legs of basic public health disease control. Next slide. So our response, as I mentioned, we started with a low-level activation out of a conference room, and then the next week we moved to our formal Medical Health Joint Operations Center because we needed to accommodate a large number of staff in order to respond to this event and provide it in a coordinated fashion. I want to really emphasize in our county, we have learned so much since we were activated for SARS, 16 years ago, and then for H1N1 10 years ago. We've learned each time, and this time one of the things that we did that made a huge difference was help from the Office of Emergency Management right at the outset. They are the experts in emergency response, and it kind of doesn't matter whether it's a fire or a flood or earthquake or communicable disease. A lot of the organization and what you do is the same, and so we brought them in and embedded them in our team, and that made an enormous difference in the efficiency of our response. So there's a couple quite a bit involved. One is maintaining situational awareness. Sometimes there's half a dozen conference calls a day with various partners all sharing different information. There's new literature published in medical journals every day, and of course there's lots of news reports, and all of that needs to be integrated to give us our situational awareness to know if and how we need to pivot here in the county. There are teams that have been monitoring anyone that's reported that seems like they might meet the case definition, whole teams doing intake, whole teams following the cases that we've confirmed, as well as doing the contact investigations. Another big component of this has been communications. There's been so many inquiries, not just from the general public, but from key stakeholders, including schools, healthcare providers, and businesses. And then an entire operation to ensure that we keep healthcare providers informed. At times we've had daily conference calls with providers in hospitals to hear what they're seeing, to understand what their issues are and what information they need, and then to try to get that information and turn it around and provide it in a manner that's useful to them. And of course, with any event, even though we have started, as I mentioned, in a way, this is a scaled up version of something that we do every day, but we've needed to develop literally dozens of new policies and procedures and tools in order to do this work. So on average, we've had about 65 staff redirected to our Medical Health Joint Operations Center every day. Most of these are from public health, but they also come from departments across the county, including the Office of Emergency Services. And as well, for the first 3 weeks, we had a team of 4 staff from the Centers for Disease Control and Prevention that were embedded in our operations center. The morning that we had of our first case, we had a conference call. They offered staff, and we readily accepted, and they were in our operations center within about 24 hours. As I've mentioned, one of the real challenges has been to have a rapid operational response even while the information is evolving, sometimes changing by the day and sometimes even changing by the hour. And this is something that we have experienced before. And I remember it very well with SARS. What happens is that we in the county might experience a case or an issue before there's state or federal guidance telling you what you need to do. We need to be responsive to our hospitals and our providers and our public and our questions before the guidance has been developed, because everybody's learning at the same time. So it really becomes an iterative process of hearing what the concerns are from providers and schools and the public, responding to it with guidance, and then revising the guidance when formal guidance comes from the state or federal level. And this is something that's happened again and again and again. And one of the reasons that we've had to devote resources in the center is just to ensure that the guidance is updated and harmonized within the state and the feds. And I would say that this is where the incident command structure has been so critically important, is keeping all of this organized. Next slide. A lot of this event has been media and communications, and the media team has been, our public health media team has been supported by communications professionals from the county executive, from health and hospital system, from parks, from fire, from environmental health. It's really been extraordinary, and they've accomplished quite a lot. 2 press conferences, over 100 individual media inquiries, lots of radio, print, and TV individual interviews, and lots of feature stories. And it's increased the visibility of public health, lots of visits to the website, and we hope people are getting the information that they need there. Next slide. So there have been, of course, a number of challenges. I would say that the biggest challenge is that this is a new virus, and there's still a lot that we don't know. We're accustomed to knowing what we're dealing with. We know the basics of a pathogen, how it behaves. We know what are the evidence-based prevention measures, and we deploy them. And with this, it's all been developed as we go. So, for example, we still don't know what the animal reservoir is. We still don't really even know how this started. We still don't know really basic information like how long is someone infectious? Do they become infectious before they have symptoms? How long do they stay infectious when they don't have symptoms anymore? Pretty basic stuff, and we still don't know. We also don't completely know the routes of transmission. We believe it's through large droplets, just like influenza, but perhaps there are other modes of transmission that are contributing to some extent, but it's not completely clear yet. And we don't know yet what proportion of cases are asymptomatic, or what we call subclinical, meaning that someone could have a very mild illness for which they wouldn't even seek care, but perhaps they're infected, and we don't know, in part because our systems aren't designed at the moment to pick that up. Then another challenge has been the limited information and guidance from our federal and state partners, and it's not a criticism, it's simply a fact that we're all developing guidance as we go and adapting as we go, and it always lags behind when we urgently need it. And finally, staffing has been a challenge. Everyone has stepped up, but we have activated our formal continuity of operations plan in the Public Health Department. We've pulled from every program, as well as now pulling from other departments, but it's a challenge. The opportunities, though, one is, I think every time we do a major activation like this, we're better prepared for the next event. And the partnership with the Office of Emergency Management, we've learned a lot from each other, and that's been very, very, very beneficial. And I also, a opportunity for us, I think, is just increased awareness of prevention. I always say that when public health is doing a great job, what you will see is nothing. Because our job is to prevent bad stuff from happening. But now, while we're doing the activities of prevention, it's been more visible, and I think that's in general good for public health. So next slide. So what should the public know? I think a couple take-homes. One is that the situation in China really is unprecedented. I don't think we've ever seen a virus emerge in one city and spread to an entire country and in many other countries in 30 days. And no one really knows what's going to happen next. We're all still learning, lots of theories, lots of ideas, but nobody really knows. However, I do feel that the current infection control practices that we are employing every day should be effective at mitigating spread, not preventing things, but bending the curve and keeping things under some degree of control. So here in the county, I also want to be very clear and stress that our declaration of a public health emergency doesn't signify an increased risk to the residents of Santa Clara County. What it's about is a threat of the introduction of this contagious virus, but it doesn't mean that it's widely circulating. Those are very different things. And we don't have any evidence still to date that the coronavirus is circulating in our county. We just have our 2 confirmed cases. And despite follow-up with many contacts, no additional confirmed cases, and no documentation of person-to-person spread here in the county. Next slide. So just in closing, I would say it's still pretty basic advice. It's still respiratory virus season here in Santa Clara County. The influenza season is in high gear. And so we say, stay calm and cover your cough, wash your hands regularly, stay home if you're sick, and avoid touching your eyes, nose, and mouth. And stay informed. Stay calm and stay informed. We are working very hard to keep our public health department website updated. And I wanted to, before I completely end and you take questions, just express an enormous amount of gratitude. Every corner of our department has been impacted, and people have really stepped up. As I mentioned, Dana Reed and his team at the Office of Emergency Management have kept us on the straight and narrow. The county executive, Miguel and Jeff, have been enormously supportive. County council, we can't do this work without county council. The health and hospital system, when I contacted Dr. Fong Nguyen and said, we're dying, we can't stay up all night taking calls from providers, we're going nuts. She said, I'm there, and the VMC physician execs have been phenomenal, absolutely phenomenal. I mean, I do not know how we would have done this without them stepping up. I think it would have been impossible. And then we've had retired employees who have come back to home, to come back to the County of Santa Clara to help out, and that's been fantastic too. So it's been, it's really sort of felt, it's been really hard, but it's also felt a bit like a family reunion, which is very gratifying and why we do the work. So thank you.
Thank you. We've got a number of questions, and then I'm going to turn to Supervisor Ellenberg, whose light is on as well. As I indicated, each of us, I think, conceptualizes these issues differently. I come at it with a 1, 2, 3. The first is the nature and extent of the problem. How big is the problem? How serious is the problem? Second is, what are we doing to address the problem? And the third is, what are we encouraging members of the public to do? So let me try and get a little bit of clarity. And I understand that some of these are terms of art, Dr. Cody, but I'm noting in the staff report that you provided, which was very helpful, by the way, January 30th, the World Health Organization declares a global health emergency. January 31st, the United States Department of Health and Human Services declares a public health emergency. February 3rd, the health officer, that would be you, declares a local public health emergency. February 10th, our Board of Supervisors is asked to confirm that declaration of a public health emergency. And on page 2 of the staff report, it says the risk of COVID-19 to people in Santa Clara County or elsewhere in the U.S. remains extremely low. So the reason I'm walking through those steps is I've got the World Health Organization using the word emergency. I've got the United States Department of Health and Human Services using the words public health emergency. We've got a declaration from your office, which has been confirmed by our board, and yet and that understandably, I think, conveys a high level of concern to people, and yet much of what I hear you say is we think things are relatively well contained, folks should stay calm, not a source for great concern, if I am paraphrasing you correctly. Am I paraphrasing you correctly?
That's correct.
So can you help us understand how those words emergency get used? And, you know, I'm not asking you for, you know, semantic reasons. I'm trying to again help. I'm trying to understand. I'm trying to help the community understand the extent of concern people should have about the virus per se. So in one of the slides that you gave us, there was I'm not sure if I saw it pop up today, there was a description of all of this in the context of comparing or contrasting with other things like the common cold or the flu. I don't know if that's
Sure,
slide
that
is
slide's,
available.
keep going. We will find it. It's one of the 3 slides after the last slide.
Okay.
So this is trying to put this new virus into perspective, and this is a slide. Keep going. There's one of the slides after the thank you slide at the very end. I'll keep going. There. And I just want to note, this is a little bit of an old slide because in this slide it's called Wuhan coronavirus, and that is incorrect. But this gives us a sense of how the fatality rate as compared to other viruses that we know about and how likely it is to spread, the average number of people infected by each sick person. So on the vertical, that's a logarithmic scale. So the big pink blob is this new virus, and what you can see is that the fatality rate is below that of SARS and MERS, but above that of seasonal flu. So right now, we think that the case fatality rate, which is the proportion of people with an infection who will die, is somewhere around 2.5%, but it's really difficult to know that, and that's because most of the cases are in China, and so we don't know that much about the case ascertainment. In other words, do we know that we've counted all the cases that are there, and we know what proportion of them are asymptomatic, mildly symptomatic, severely ill, et cetera? So that's sort of it's a working figure. Then you can see It's also important to know what's something called the reproduction number, or for every case, how many individuals become infected from one case. And it looks like that is somewhere about 2.5 for this new virus.
So,
Which is, for example, measles is around 18, so it's far less infectious than measles.
thank you. So if I forgive me, doctor, I know you're trying to be precise in the language, but I'm trying to cut to the chase on some of this. So is it fair to say, is it accurate to say that at the present time, we think it spreads about as efficiently as the common cold, looking at where the common cold and the coronavirus are on this chart?
Yeah, or maybe a little bit more.
Okay. And it is, while not as serious in terms of potential lethality as the items there, it is clearly much more serious than the common cold, and at least as serious as what we consider to be the seasonal flu here in the United States and in California and in Santa Clara County, yes?
So this is interesting that you bring up the flu, because although the case fatality rate for this new virus seems to be higher than for seasonal flu infects so many people that the numbers of people who are hospitalized and die is still larger than that for this new virus, if that makes sense.
And whenever we hear from you about the seasonal flu at the Health and Hospital Committee, you take the opportunity, as I recall correctly, to remind us that the concern is greater among what we might think of as vulnerable populations, including folks who are older and or who have other health challenges. Am I remembering that correctly from previous conversations?
That is correct, Supervisor Simitian. However, we still do recommend the influenza vaccine every year for everyone 6 months and older.
Thank you. And then if we could go to slide 4, which was the timeline slide. And I notice on January 17th, we've got the airport screening, SFO, JFK, and LAX. What about right here in San Jose?
So the Division of Global Migration and Quarantine is not at San Jose Airport. They're in San Francisco. So there's not a team from the CDC embedded in San Jose, just in San Francisco. So the flights were directed back through airports where DGMQ has a presence.
Let me rephrase my question then. Do you feel confident that the flights that are coming to San Jose are not flights that require that kind of screening?
So the rerouting of flights is something that's been one of the areas where there's been a lot of flux and change. So not everything is on this chart, but the airport screening and through which airports was, changing every 12 hours there for a little while. And I don't think I can reconstruct it for you. What I can tell you is that as of today, there are far fewer flights arriving back to the U.S. and to California from mainland China. And the flights are now, as of February 2nd, travelers returning from Hubei province go into federal quarantine. So they're off at Air Force bases. Flights coming back from mainland China, not Hubei province, come through the airport. Their travel history is recorded, and the Customs and Border Patrol provide that to the Division of Global Migration and Quarantine, who provides it to the State Health Department, who provides it to the County Health Department. And then we follow up with those return travelers.
Again, I'm going to try and bottom line it. So if somebody in my district asks me, should they be concerned about the fact that there is not screening at San Jose Airport, is the accurate answer flights that require screening are going to other airports?
That is the correct answer.
Okay, thank you. Could we see slide 5, please? I wonder if just in terms of these 3 terms of art, and again, I very much appreciated the simplicity of good case identification and then good contact tracing. What does the phrase good disease surveillance mean in the context of this slide, Doctor?
So this is this slide is generalized for any outbreak. For this outbreak, we are relying on both the exposure history. So have you traveled to a place where this new virus is circulating, as well as laboratory confirmation. And currently, the only lab in the United States that is confirming cases is the lab at the CDC. They have many other labs, including our public health lab, will soon be able to provide the test, but not as of today.
How soon do we think soon is likely to be? Is that a matter of days, weeks?
Probably a matter of days, but we don't have a date.
Okay. And you mentioned on Case ID, then isolation. My understanding is we still have only 2 cases here in Santa Clara County. Am I right on that?
That's correct.
And there was a phrase in the newspaper, and forgive me, I may not remember it correctly, self-isolation. Am I remembering the term of art correctly?
So both of our cases are still at home, isolated, meaning they're not having contact with anyone else.
And understanding, obviously, the concern about civil liberties and freedom of movement, and so what do we say to people when they say, well, how do we know these folks aren't moving around the county and having contacts that pose a potential public health risk?
You have to trust your local public health officer.
Because my local public health officer is doing what?
So one of the we do formal orders, legal orders of isolation and legal orders of quarantine when we deem it necessary.
Has that been done in these 2 cases?
Yes.
Thank you. There is a distinction that I just want to make sure I understand. There's talk here about person-to-person transmission, but in the staff report indicates that to date there have been, I think there's a missing word, there have been no instances of community transition in the U.S. Could you describe just for me in layman's terms what the distinction is between person-to-person and, quote, community transmission?
Yes, so person-to-person transmission is transmission of the virus from one person to another, but we distinguish that from if there's person-to-person transmission, for example, to a family member or another close contact, then we can trace the chain of transmission. If there's community transmission, that means that it's circulating in the community, sort of like influenza. When you get influenza, you can't trace back, well, who gave you influenza and who gave them influenza. You wouldn't be able to trace it because it's circulating in the community.
Okay. In terms of what we would recommend for the public, if we could go back to that slide, if that's possible, please. And then I want to turn to Supervisor Ellenberg and thank her for her patience with my many questions. As things now stand, should members of the public have any concern about attending public events, going to a concert, a movie, an athletic event?
No, we have no recommendations to cancel large gatherings. We have no recommendations to wear masks. We, again, have no evidence that the virus is circulating. And nor do we, despite looking fairly hard for person-to-person transmission, we've not even documented person-to-person transmission in our county.
And that would mean then presumably no reason why someone shouldn't send their kids off to school every day.
We encourage everyone to go to school every day, go to work every day, carry about your life. The only thing I would say, and this is general, is If you are sick, stay home with whatever you're sick with.
Thank you very much. And I want to just hone in on something that you said, which is we have 2 cases here in the county. They both are understood to have come from where?
So both of our cases had a history of travel in Wuhan, the epicenter of the outbreak. And there's now 15 cases in the United States. I think we still distinguish ourselves as the only jurisdiction with 2 independent travel-associated cases. The other jurisdictions with pairs of cases, one was a traveler and the other was a close contact to the traveler.
All right. So if I was trying to provide some reassurance to somebody in my community, what I might say to them is that in a county of 2 million people, we have only 2 identified cases. Both of those cases are thought to have originated outside the country, that they are both in isolation and being carefully monitored, and that we have no evidence to date of any other transmission within our county. Was all of that accurate?
That is accurate.
Thank you. I may apply for an internship one day. So there you go.
You may now come work in the Medical Health Joint Operations Center.
I'll leave that to the
Congratulations.
experts. Thank you. Supervisor Ellenberg, thank you again for your patience. Comments or questions?
Thank you. Yes, Dr. Cody, you were very gracious in thanking just about every department in the county, and I want to extend my gratitude to you. The professionalism that you have led with this very calm and measured and accurate and detailed presentation of all of the facts in a very timely manner since December is noticed and really appreciated, and has helped my office, and I assume the others, be able to disseminate information in a way that has kept our constituents calm. So thank you very much for that. We have gotten a couple of constituent questions about when and how testing will be provided for COVID-19, for the disease, outside of the CDC. And I'm wondering if you have any updates on testing expanding to other labs, and is there any expected impact for your response here in Santa Clara County?
Thank you for the question. So currently, I believe it's just the CDC lab that's still testing. There was a plan to send the reagents to 191 other laboratories, all public sector laboratories, state and local health departments. There's been some issues with the test, so the test is not yet up and running and available in those labs. Our labs will be one of those labs, and it will help in a number of ways, including shortening the turnaround time. So, for example, if a physician calls, they're concerned with a patient that they're caring for, and we would like to test them, there'll be much shorter turnaround time because we'll be able to do it in our laboratory. I would imagine that with time, the tests will also there'll be some uptake in the commercial sector, and it will be more widely available, but that's not the case now.
Okay, thank you. And you mentioned, or Supervisor Simitian mentioned, the flu as well, and relative transmittability. Where do we stand with regard to numbers, mortality of the flu season in Santa Clara County, and how do you see this new disease, COVID-19, and the flu response in relation to each other?
A couple comments. During the influenza season, we have weekly calls with providers to understand how hospitals are being impacted by the flu season, and then those have been transitioned to COVID-19 calls. So we discuss the flu and COVID-19. Right now, what we know from our surveillance data here in the county and the state is that there's a lot of flu activity right now. It's fairly widespread. It is difficult because the presenting symptoms for COVID-19 and for influenza, of course, are quite similar.
Are you hearing from physicians asking for testing more frequently or more often when patients present with typical flu symptoms?
No, the key here really is the exposure history. So if someone's not had travel to mainland China, we don't consider them to be at risk for COVID-19 and don't test.
Thank you. That makes sense. My last question is, what is our plan for maintaining response operations over time if additional travelers are assigned for follow-up and our surveillance activities need to continue?
We have an entire section that just works on staffing, and we're pulling staff from public health and may increasingly be needing to pull staff from other parts of the county to keep the response going. It has been a 7-day-a-week operation, although on the weekends we've had a smaller footprint. Much of the activity now is around follow-up with returning travelers. Those lists that I mentioned that we get.
Okay, I hope soon that they will have nothing left to do. Thank you so much.
Thank you.
Thank you. Dr. Cody, before I ask if you have any other comments or observations you want to share, I think I would just turn to, well, both you and Dr. Smith and say we've had in this committee on prior occasions some conversation about how to proceed going forward when we're in the midst of something like this. And again, my exhortation to our professional staff is to err on the side of caution, which I know is your default, but also to devote such resources as you think are necessary to make sure that we stay ahead of the curve on matters of this sort. I know that from time to time staff is concerned that if they expend resources and then there isn't a problem, that someone will wonder whether or not those were funds well spent. And to your point earlier, Dr. Cody, the absence of a problem would be a good place to find ourselves. So I just I want to sort of provide that reassurance to staff that I'm not inclined to be second guessing the expenditure of resources to make sure that we keep the problem in check. I never complain that my house doesn't burn down after I paid for my fire insurance. So, I just sort of take the same view here in terms of making sure we put the resources where you think they're necessary. Dr. Cody, anything else by way of close?
Thank you for the opportunity.
Dr. Smith, anything else? No? All right. Well, then we will say thank you very much to the team, and I will ask Supervisor Ellenberg for a motion to receive the report. This is item number 4 for the clerk, and without objection, the report is deemed received, and that means we can say thank you very much, and we will go back to item number 7, where we freeze-framed you, Mr. Santiago, and if you want to take a moment or two to get the right charts up, we can do that. Thank you.
Well, and yes, thank you. Back to the coverage update. Pretty much this is what we're recommending at this point in time, and I think we left off about the discussion as to whether this would discourage people from pursuing, whether it be Medi-Cal or Cover California or other things. And at the end of the day, what we're trying to communicate here is that we'll provide the financial assistance to pursue those things. We provide help for people to do their paperwork, educate them about their options, but we don't want them to delay their care or tragically become disabled or otherwise because they didn't get the necessary medical care in time. So that concludes my presentation. Obviously, any questions you may have.
Thank you. Supervisor Ellenberg, you, if I recall correctly, shortly after you were sworn in, you were obliged to sit through my State of the County remarks on health care. Am I remembering the timeline correctly here?
You are indeed.
And you will recall that I chose to focus my remarks exclusively on the issue of health care and particularly on taking what steps we could to make sure that no one got left behind. So this is very much in keeping with my remarks at the time and with staff's best professional judgment, entirely independent of anything I might have brought to the conversation. So thank you for that. I guess I would ask a couple of broad questions, which is for you, Mr. Santiago, or for the county executive. Timeline on moving forward with this. Can you give us a little more clarity about what that might look like?
Yes, we're targeting for the March meeting at the Health and Hospital Committee to come back with the policy So that way you have a little bit more detail in terms of what we're proposing, and then obviously after that, subsequently to the full board.
And is there a teaser here on what the cost implications might be? Because I know that's going to be a concern.
I don't think we can accurately give you a cost estimation until we're sure about the policy and procedures, so we will try to attach that when we come back.
Thank you. And then, if I understood you correctly, Mr. Santiago, subsequent to our next health and hospital meeting, we would hope to have a policy we could bring to the full board for formal action, yes?
Correct.
Got it. Okay, thank you. I will just indicate again, on the American Community Survey, I know when we were trying to count close to 2 million people, trying to identify who has health insurance and or access is a tough one. I know the number 95.9 comes from there, and I know that in some respects, as the staff report indicates, people think that's a relatively conservative number. On the other hand, I am always a little concerned that the American Community Survey, by definition, doesn't get to the hard-to-reach populations that you have identified as being among those who are most likely to be in the hard-to-enroll populations. So, we need to land on a number just to have a number as a point of reference, but I am worried that there are folks who aren't counted who might make that number a little less robust rather than more robust. Supervisor Ellenberg, comments, questions? I want to be mindful of the fact that you have to exit here pretty soon.
I don't have questions on this item, and if it's possible for us to zip quickly to 9, I would love to just put some questions on the record. I won't be able to stay for the responses, but would ask for an off-agenda report.
Sure. So what we're going to do, and ask both the staff and the public to just bear with us here a little bit. We're managing schedules. Is I'm going to ask Supervisor Ellenberg to move approval of 7, 8, and 9, which is simply to receive the reports. There's no formal action there. She has made that motion, and without objection, so ordered. If there are speakers on any of those items, I will be here to hear them when the cards come up, and we'll ask David to hold on to them for the moment. And so back to you, Supervisor Ellenberg, if there are questions or concerns you'd like to raise now so that they can be followed up on.
Thank you very much.
Please do.
Thank you. And I will be able to hear all of the public comment as well, because I will listen to the recording of this meeting later. My questions are on item 8 on the hospital integration report. Is John here?
Mr. Mills, you want to come on down?
Just for looks, John, since I'm not going to ask for the answers right now. But the first is, given that we're at the 1-year mark of hospital integration, as you look at patient volumes, I guess this is more for Paul or Dr. Smith, but I'll come back to John next, that we're at the 1-year mark of hospital integration. As you look at patient volumes, revenues, and expenditures, how do we stand, given what the expectations for the integration process was at this point, and what is your outlook for the coming year? I realize that's a longer answer, and I'm happy to get that either orally here or off agenda. And for John, I have a couple of questions. There's still 144 people remaining in provisional status. So I'd like to know how many of those do you predict will need a retroactive start date? And do you predict that any of these will be hired into an unclassified position? And some additional comments that I want to make in preparation for the board meeting on Tuesday. I would like to see a layout. I would like it to have you lay out a timeline of the expiration dates for each unclassified position, any scheduled countywide testing dates for these classifications, and identify dates by which each employee should plan to test to allow for up to 3 testing opportunities under the merit system rules outlined in the report. I'd like you to use this information to prioritize and group classifications in batches, I guess, for support, including deciding what, if any, modifications to the testing process will need to be made for each classification. And I'd like you to outline a plan to communicate the sequencing of classifications to the impacted employees and their managers so that they all know what to expect and when. I believe that it would be really helpful to have these for next week's board discussion, or if absolutely necessary, through an off-agenda report to make sure that we have a clear plan and next steps, and then follow up through future HHC discussions on the progress, perhaps at the April HHC meeting. And if all of that is acceptable to you, Supervisor Simitian, I'll look forward to the responses.
Duly noted.
Thank you. And if, John, anything in that wasn't clear or too quick, Kelly is here and can follow up with you, and happy to work with you between now and the board meeting.
Great, thank you.
Thank you so much.
All right. That takes us back to item number 7, and I think what we're going to try and do is wrap up by 12:15, 12:20, 12:30 at the latest, folks. So staying with item number 7, the Mr. Santiago, forgive me, I'm at a rare loss for words, and the reason is what I'd like to ask you to give some thought to between now and the time you come back is how to simplify a very complicated set of behaviors. Sure. And because as I listen to you both today and previously, and as I read the materials, both that we got today and that which we've received previously, it's clear to me that it's not as simple as saying it shall be done, and it's not as simple as saying, well, we're just going to create a new program and we're going to call it Y'all Come. Right. There are sort of multiple different paths towards making sure that we get to that last batch of folks who are so tough to reach. So what I'm asking is if you can give some thought to how to communicate that both to the board, but also to the broader public, so that people don't get lost in the weeds. Right. And maybe it's just as simple as, you know, giving it a name. But as I said, if it's as if it has too many moving parts, I'm not sure we're going to be able to communicate the fundamental message, which is if you need health care, we're here to provide it, which I think is the message we're trying to send. Correct. All right? That takes us on to item number 8. And do we have cards on this item? We do. Thank you very much. And why don't we hear from Mark Quarles, Lon Nguyen, and Carlton Allen again, please. Come on up, folks.
Good morning. My name is Mark Quarles. I work at St. Louis Hospital. The integration is not going so well. I'm not here to cast blame. All of you guys are doing an awesome job. Our hospital executive, Ms. Gloria de la Merced, is doing an awesome job. But at the same time, she's being asked to race in the Kentucky Derby with a mule. That's basically what's happening. And us mules, we're doing the best job that we can. But you guys need to give her some more support. One of the things going on right now is our extra help workers have basically run out of hours. So what is our hospital executive supposed to do at that point? Tell us mules to work more? hire out contracted workers? Why not extend the hours of our extra help workers that are already doing the job well, know how to do the job? Why should we contract out and bring in work that costs 10 times more when we've got individuals that want to work and know how to do the work? At our hospital, we've got a CAT scan unit that seems to go down every 10 to 15 days. How can our hospital executive be required to meet the standards of a stroke center when our CAT scan unit goes down every 15 days? It's time for something to happen. We need your support so that we can race in the Kentucky Derby. Thank you.
Mr. Quarles, before you
Yes,
step
sir.
away, I have a question for you, and if you want to take a rain check on it, since I'm just going to offer it up now, or if you want to take just a moment to think about it. One of the challenges when we hear so many different case-specific concerns is sort of trying to draw a bigger picture conclusion. And so if I were to ask you, and I know there's lots going on, but if I were to say sort of overarching, the single biggest concern you have a year later is what? Could you fill in the blank for me on that one? And again, if you want to take a minute to think about it, that's fine. If you want to get back to me at some other time, that's fine. But I'm trying to take all these different pieces and put them together. I know what I think I've heard, and I'm happy to share that with you, but I don't want to put words in your mouth either.
Right. I'd like to hear what you have to say, sir.
Mostly what I think I've heard is to grossly oversimplify a very complex set of circumstances is you just don't think there are enough bodies on the job for the level of demand that you've got.
I would agree with that 100% to a degree. One of the biggest challenges that we have is that we were a community hospital and now we've gone into the major leagues. We are seeing more patients, sicker patients, and we're being required to do a heck of a lot more with fewer resources.
I'm going to say thank you there, but I just wanted to make sure I was getting it as you were sharing it. Okay?
Right. And I think
I
one of
really
the
do
other...
have to say thank you there. I
Okay,
apologize.
thank you.
Thank you, because I want to make sure I hear from Lon Nguyen and from Carlton Allen.
Hi, my name is Lan, and I'm from O'Connor Hospital. I'm being told that provisional employees have 6 days left, so by Monday, they all have to get out of their provisional jobs and into a regular county job position, or they will be terminated. We have provisional employees with national licenses and have been doing their job for years. Literally overnight, these sonographers are being told that they're not qualified to do their jobs because their national licenses are not recognized by the county. Their classification is currently being reviewed right now by HR, but in the meantime, what happens to these healthcare professionals on Monday when their provisional status is going to be terminated? Is there a plan for these workers? But better yet, is someone going to let them know what's going to happen? Is this communication is going to happen? That's probably the biggest problem right now. And on a different note, and this is regarding provisional employees, last year, Jeff Smith came to O'Connor and said to us that many of the provisional employees who didn't pass the HR placement test, there would be a task force to include subject experts in the fields affected to address the HR placement testing issue. The task force's goal is to work on a testing alternative for workers to go from unclassified to coded positions. To date, at every local 521 meetings with ESA, in an attempt to begin on creating this task force, the ESA has claimed that they have no knowledge of this promise that Jeff Smith has made, and they refuse to form any of these task forces to get the ball rolling on this.
Go ahead and finish your question.
Thank you. What will happen to all these people, the unclassified positions? Did ESA miss that
Thank
communication?
you. Now I'm going to say thank you very much. The
Okay, thank you.
point made and heard. And Carlton Allen is our third and final speaker on this item.
So this is just on for Susan, just some extra information I wanted to give to the clerk to pass on to you. With the integration, what I've experienced is, I think when you ask Mark, what is the biggest single issue? I think there's some type of direction loss. Dr. Smith and everybody is working hard, but then we haven't had a meeting with Labor Relations and ESA since November or December on the misclassifications, anything. There's not been a meeting, there's not been any type of work done moving forward. I don't know where the blame lies, why that happens. I don't know if it's SEIU, I don't know if it's management. All I know is that every level of manager I talked to, except a few, has been great here. I just want to give that. I cannot explain how great the work that the executive management at all three facilities has been. They have been welcoming to me. When I contact any one of them and ask them a question, I really want to get that apart. But I really say that the answer lies with the workers. And they're not included in conversations. And as long as we avoid that, honestly, we don't need ESA, we don't need labor relations, we need management and workers side by side answering the questions so they can come to Jeff Smith and Renee and everybody and give the answers, and this is the way we solve it. As long as people that aren't on the ground is there, right now all I see is a bunch of confusion and there's no direct contact with the workers. So for me, the end result is we need to get together. I don't care if it's 5 of us or 10 of us, but have the power to make the change to effectively get us to where we are, because there's bad.
Thank you very much.
Thank you.
Before we move on, and understanding that Mr. Lorenz is not here, I just wanted to ask if there was a member of staff who could comment on what appears to be a significant drop in the commercially insured population at O'Connor.
Manesh, do you want to comment on that?
Is there a known reason for that? Should it be a source of concern? Thoughts? Should we get a microphone that works for you before you answer? There we go.
To turn it on, perhaps,
go.
that helps. So we have, since the integration, seen a slight decline, in my opinion, a slight decline, but progressive decline in our commercial population. And some of that is, in my opinion, because we have lost some of our primary care referral community physician base. And so we are working on many projects right now that is in an effort to kind of recapture and regain some of the outpatient physicians that have been watching the integration very carefully. And I think what they're seeing now is progress and movement in a very positive direction. And we're now finding that many of those private physicians are reaching back out to us and re-engaging with the hospital system. So I'm optimistic that we're going to see that normalize and change in a positive direction in the very near future.
Thank you. And forgive me, could I get your name again?
It's Manesh Bhamani.
Pleasure to meet you. And there's a gentleman sitting in the chamber named Matt Savage who's just raising his hand. I'm going to ask the two of you to be in touch, and I'll follow up through him, if I may.
Great.
Thank you so much. All right. I have no additional questions at this time. Are there any additional comments? The report has been received. I see Dr. Smith, you're leaning in, sir.
I think since Mr. Lorenz is out today, we should probably just move ahead, and then we'll have more thorough report next time.
All right, thank you. Then that would take us to item number 9, which is the update from the director.
Yes, Mr. Chair, given the time, unless there's any questions, be happy to answer any particular concerns.
And are we talking about, do we have cards? We do. Thank you. I will pass on questions today. Thank you. Except I will say again, both for you and Dr. Smith, but for the entire team at the dais here, coverage expansion remains a priority for me as one member of the board and as the chair of the committee. So we'll stay there, understanding that coverage expansion may mean use of different tools in different venues. On 9B, we've heard from Dr. Cody. Unless there's Dr. Cody, I didn't mean to cut you off. I see you've returned. Anything else on other topics?
No.
Thank you again for a very helpful report. And then that takes us to 9C, which would be Mr. Lorenz. Does he have someone here to speak in his stead? Anything you want to share?
That would be me, Jill Sproul, the Chief Nursing Officer for the enterprise. And since you're going to delay the report, I don't have anything else to add, unless there's any questions.
All right. That does take us to 9D, which is behavioral health. We do have a card for Mr. Largent. Mr. Largent, are you in the room somewhere? Apparently not. We will ask Ms. Tullies, what would you like to share today?
I think the biggest thing to share today is that we are filling our executive positions with fabulous employees. So we've been able to fill 3. We've interviewed 1 this morning. We have more next week, so that's very exciting. But given the time today, I think that that's all I would focus on, Supervisor, because we'll be providing a big,
all right,
a big report next month.
That then would take us to 9E, Valley Health Plan.
Thank you so much. So I would like to share that we have brought in Gelsane Gez as our new Chief Medical Officer. We're very excited to have her join us. And in other exciting news, Covered California has extended it's gone to a special enrollment period, so they will now allow folks to enroll in Covered California through the end of April. So that opened as of yesterday and will go to the end of April. So we plan on doing some more outreach events as well as putting some information on our website. And our current numbers of effectuated members is 21,703.
Anything we can or should be doing by way of outreach, advertising, given the extended date?
Yes, I think we definitely should be doing that, and we're working on that. This was pretty late breaking.
Right.
So we have a number of events working with the Earthquakes, the San Jose Giants, a few other community events scheduled throughout the next couple of months. And I'm looking forward to partnering with folks around the county and getting the word out.
All right, here again, suppose we could blame the Russians. Mr. Savage, I'm going to want to follow up with you on this item as well, please. All right, thank you. That takes us to 9F, Emergency Medical Services Agency. Anything to report? We're having trouble getting the stroke data that we need on a timely basis. I know we've been in touch with your office. I don't need a report right now. I'm just going to say we need to get this issue resolved sooner rather than later, please. Okay. Custody health?
No report at this time.
All right. Federal health policy and budget landscape.
Yes, I'm here.
Yes, you are. Thank you for being here.
Chairman, happy to be here.
And I applaud my colleagues' concern about getting some certainty in the system, but thoughts about where we are and whether we're going to get any certainty anytime soon?
Sure, I'll start with Supervisor Ellenberg's question, a very important question to raise. There are lots of risks out there, lots of uncertainty, but I very much agree with your response, Supervisor Simitian, that we've been living with this uncertainty for a very long time, really since the Affordable Care Act has passed. Almost every year there's been some threat or risk we've had to contend with. And the model for what we should be doing in many respects is what Governor Newsom is doing. He's facing these same threats on a statewide basis, and yet he has a very ambitious program for Medi-Cal reform that he's trying to promote. He has coverage expansions he's trying to advance, and the county should be doing the same at our level to the extent we have the resources. The key is to be mindful of the threats so that should we have to change course based upon something becoming real, something becoming enacted, we're not blindsided by that, but it's not a basis for inaction.
All right.
So other issues briefly, Congress is still dealing with the surprise billing issue. There are multiple bills that have been developed. Speaker Pelosi is trying to reconcile the multiple bills from multiple committees. The main reason we're following surprise billing is this is a source for a budget offset that could allow our dish cuts to be deferred that are a risk to the county's finances. Again, with Speaker Pelosi involved, there's some chance of an agreement or an arrangement before the year is over. We'll see. Drug pricing also seems to be stalled for the moment. The House has passed a comprehensive drug pricing bill. The Senate has its own bill, which the president has tentatively shown some level of approval for. The problem really is the Senate Republican leadership doesn't want to involve Health and Human Services in any kind of direct pricing action, government control of prices. That's Senator McConnell's concern, and even Senator Grassley's much more modest proposal that essentially tries to keep the year-over-year increases held to the cost of living is viewed by the Senate leadership as government control of pricing. So there's a lot of work to be done still on drug pricing, differences within the Republican Party that have to be reconciled. On the budget front in general, there was a report when the president's budget was released that there were major Medicaid cuts, and there were hundreds of billions of dollars in Medicaid cuts over a decade. The good news in all of this is that the president's budget is not, I mean, every year president's budgets tend to be dismissed. This budget is being dismissed even more aggressively than in past years because there's no detail in it. And it's not, and therefore the risk of significant cuts is pretty small this year. On the regulatory front, we're still watching the MFAR rule, the Medicaid Fiscal Accountability Rule. That's the rule, the regulatory action that we've talked about multiple times that poses the biggest risk to our Medicaid financing. When Supervisor Ellenberg raises the question of uncertainties, this MFAR rule is one of the most significant ones out there. Comment period just ended. Seema Verma, the director of CMS, is very aggressively defending the rule. She knows it's under threat from all the critics around the country who've said it's going to produce a negative outcome for the Medicaid program, not just California. It affects dozens of states. But she seems quite determined to move ahead, and we'll know by May, June what the final outcome is there. Public charge rule goes into effect February 24th. It's only been enjoined in one state, Illinois. The rest of the country will have to contend with it. There's still litigation on the merits of public charge. We lost the injunction battle, so we'll go ahead, but the legal battle over whether or not it's permissible policy is still being pursued. Block grant waiver guidance was issued by CMS recently. Won't affect California directly because we're not going to take up the block grant option, but it's out there as an initiative by the state, by the federal government, I should say. There's also been, I'll mention this very briefly, a couple of court decisions worth referencing. Title X gag rule that's out there as a rule. Court in Baltimore issued a decision blocking the rule for the state of Maryland, arguing that it violated the Administrative Procedures Act. Again, it's a victory in the fight to stop this rule from going forward. There also was a 3-judge panel in the D.C. court that struck down the Medicaid work rule in Arkansas, another issue we've been tracking, calling the rule arbitrary and capricious because it did not actually promote the purposes of the Medicaid program. CMS has been trying to argue work requirements are good for the program. This 3-judge panel unanimously said it's inconsistent with the purposes of Medicaid. And the last issue I'll touch on only there are two final issues very briefly. We've been following the Texas versus the United States case, the major threat to the Affordable Care Act. Most recently, there was an effort by several attorney generals to get an expedited review by the Supreme Court. The Supreme Court said no to expedited review, which led us to believe the issue would be deferred until 2021. In the last couple of days, there have been multiple press reports that while expedited review has been denied by the court, that the Supreme Court, in fact, is going to discuss in a closed conference later this week whether to take the issue up during this term of the court. No indication as to whether or not they're going to do that or not, but we went from an assurance that it would be deferred until 2021 to now there's at least a possibility, and we'll know the answer later this week, that it could be before the court this year. And on the issue of covered California, yes, sir.
Excuse me,
certainly.
Ms. Margot. Will we know the answer to that later this week?
Well, the closed door conference will be held. I don't know enough about Supreme Court rules and could defer to County Counsel on this issue to know how quickly afterwards they're likely to tell us. Mr. Press, do you have an insight you want to share?
Typically, they issue orders very quickly, but they also can defer consideration. In a case that I was involved in years ago, that we got kicked over a number of times, so we didn't actually have some certainty at the outset what the ultimate decision date would be.
So we may just hear silence.
We could. We may.
Okay, thank you.
And final issue that actually you heard about a moment ago from Valley Health Plan involved Covered California's decision to extend enrollment, open enrollment for Covered California. Again, that's connected, that announcement, to some good news about an increase in new enrollment in Covered California, a year-over-year 41% increase in new enrollees. A little bit of bad news attached to that in that the re-enrollments, people already in the program, dropped 8%. So it isn't all good news, but on balance, the program, and this is being attributed in part to the state's decision to apply its own individual mandate and create its own subsidy fund, that those two decisions, Covered California is suggesting, help them get this significant increase in new enrollment. And that's just worth noting, being aware of. And that completes my report.
I will say thank you.
Thank you.
And in the absence of any questions or comments, that wraps it up for today. Thank you very much. Without objection, meeting is adjourned. Thank you.